Dear colleagues, well, first of all, thank you very much for your invitation, which actually was a bit of a challenge for me. Why? Because as a young neurologist, I actually started with neuromuscular diseases. So the first, my first subspecialization when I worked at the Institute of Neurophysiology was actually patients with neuromuscular disorders, and now at the last part of my professional career, I'm working in the field of cognitive impairments. It was quite a journey, I must say. So today I will tell you something about cognition in neuromuscular disorders. So in neuromuscular disorders, we know that there is something beyond weakness. There can be more things or symptoms beyond weakness. One of them may be, but not need to be, cognitive impairment. Now, I know that most of you know this beautiful painting. It is a fresco painting in the Sistine Chapel, where Michelangelo in early 16th century draw a moment when God is supposed to create Adam. Now, there's something interesting about this painting, namely, Adam is already created. He is created there in all his Renaissance muscular beauty, and the God is pointing to him. He's encircled with angels. Now, somewhere mid-90s, what happened is that two neuroanatomists, American neuroanatomists, walked the Sistine Chapel, and one of them looked at this scene and he said, "Look, don't you think that actually the group around God and God himself, that it is actually a image of human brain. Human brain looked from the midline, so the so-called sagittal view." Of course, neurologists were very enthusiastic about this interpretation. Other people didn't really believe, and they just said, "Okay, you send a neuropathologist to a Sistine Chapel, and he will see nerves and brains and stuff everywhere. You send some other specialist, I don't know, urologist or gynecologist, or you name it, dermatologist, you will see other things." However, we know nowadays that two neuroanatomists were right, because in the same Sistine Chapel, Michelangelo drew two other paintings. One of them is the moment when God divides waters from soil, earth and waters, and there the God is in the form of a human kidney. And then there's another painting where God divides night from day, light from darkness, and what you can see in God's neck is a perfect reproduction of a brainstem, of the lower part of human brain. So we know now that Michelangelo, in the times when it was not permitted, it was not allowed actually to do autopsy, because soul and body were considered like one entity. But we know, of course, that in the darkness of the night, Michelangelo would do autopsies, and he would be very proud of his anatomical and neuroanatomical knowledge. It is, you know, an interesting interpretation, like maybe Michelangelo 300 years before Darwin wanted to say, look, God did not really create man, but God gave man something which is maybe the most precious gift of them all, and this is he gave him his mind, something what we cherish having in our brain. Now, why did I start this? Because in the field of neuromuscular diseases, which looked so uniform and so in a certain way maybe hopeless or pessimistic in the years when I was dealing with neuromuscular disorder patients back in 80s, and now we have so much new knowledge which came from genetic. We have so much new knowledge which came from histology, from neuroimaging, from biochemistry, and we have so much more possibilities actually to treat these disorders as well. However, there are also new knowledge in other fields, like it seems that in some neuromuscular disorders, apart from weakness, there are other systems the other systems may be involved, also the systems for cognition. So several studies clearly showed correlation between molecular defects in genes, which are mainly responsible for muscle diseases and cognitive impairment. And from this point of view, we can actually divide them into three groups. First are neuromuscular disorders with cognitive sort of deficit and a known genetic or protein deficit, which is associated with alterations of cerebral function. In the second group are neuromuscular disorders with cognitive deficits, but without a defined genetic biochemical abnormality. And then the third group could be neuromuscular disorders without or with very, very poorly defined or rarely shown cognitive impairment. The best representatives of a group where neuromuscular disorder is associated with cognitive deficit and known genetic lesion are Duchenne muscular dystrophy, myotonic dystrophy, and mitochondrial encephalomyelopathies. In the group with cognitive deficits, but no defined genetic abnormalities, we can see congenital muscular dystrophies, congenital myopathies, amyotrophic lateral sclerosis, then adult polyglucosan body disease, and limb girdle muscular dystrophies. And yeah. So let's start with disease which are so very bound to dystrophin, and which was so nicely and aptly actually described for the first time by Duchenne in his article Recherche sur la paralysie musculaire pseudo-hypertrophique or paralysie myosclérosique. So the name already told for what that time was the essence of the disease. So we now know that Duchenne muscular dystrophy is a recessive X-linked disease which affects 1 in 3,500 males predominantly, and actually it was Duchenne who, in his original description, already commented on poor language and dull intellect. We know that muscle weakness first appears in very early age. We know about the genetic and the protein picture of the disease, that there is absence of dystrophin, a protein which is associated with the sarcolemma in skeletal and smooth muscles. But we also know that some of the isoforms are also expressed in the cerebral neocortex, in the hippocampus, and in the cerebellum. So the number of how often cognitive impairment may be in Duchenne muscular dystrophy in recent years increased. So Lots of people would cite somewhere a number between 20 and 50%, and would comment that in normally developing populations, that number would be approximately 9%. It's characteristic that impairment is not progressive and that it is really not correlated with the severity of DMD. What are the main characteristics of cognitive impairment in some of the DMD patients? Predominantly poor expressive verbal abilities, then deficits in short-term memory, quite often are selective reading, writing, and calculation learning disabilities. There is a very significant sparing of visual spatial cognitive abilities, which points toward more anterior part of the brain being more involved. And this is confirmed by about 10% of ADHD, attention deficit hyperactivity disorder, about 3% of autism spectrum disorder, about 5% of OCD. Now, it's interesting that these impairments do not depend on motor handicaps because we have a nice model. Some patients with similar diseases, SMA, do not show these deficits. Of course, there are variants of dystrophy phenopathies, and in Becker, we've got this variable age of onset and rate of progression of muscle weakness. And also in Becker, we can see difficult readings, 1 in 5, spelling 1 in 3, arithmetic 1 in 5 or 4, which makes them significantly more affected than in general population. And there are some studies which would show to some behavioral impairments in 60% and also about 10% of autism spectrum. So it's interesting that actually probably Duchenne and Becker muscular dystrophy are somehow reminiscent of what I remember from the field of dystonia. I remember that when I studied dystonia, that dystonia, of course, was purely and merely motor disorders. But back in 90s, people would start studying, and when you study, you quite often find. But for the time being, again, in most of the textbooks on dystrophinopathies, you will find tables like this, which will tell you about Gauer sign, pseudohypertrophy, cardiomyopathy, scoliosis, contracture, respiratory insufficiency, comparing different dystrophinopathies and trying to divide them, but very, very little would really be written about the cognition. Now, in the second group are diseases where we've got a cognitive deficit and some cerebral abnormality, but no defined genetic or biochemical abnormality, or not in all of them. Cases like myotonic dystrophy, where we can see muscle loss and weakness, myotonia, cataracts, and in men, we can see early balding and infertility. We can divide them to classically type 1 and type 2 with mutations in different genes. Now, the gene so this is the picture of Hans Gustav Wilhelm Steinert, who so nicely described this entity. Now, we know now quite nicely what's wrong and where, in which chromosome, the genetic error is, and we know that this DMPK, which is dystrophia myotonica protein kinase, which is involved in myotonic dystrophy, is synaptically localized also in the central nervous system, in cerebellum, in midbrain, in hippocampus, and in medulla. So compared to DM1 and DM2, much more is known about possible cognitive impairment in DM1, whereas in DM2, either this is not so present or studies are still not out there. So in myotonic dystrophy, we can see somehow different profile of a cognitive impairment if this starts early in adult life or later. Now, if it starts early, and it seems that there are two different processes, maybe. And now, when it starts early in adult life, it's a lot of signs for what we call frontal cognitive signs, which would involve executive functions and language, also visual memory, not in the sense of visual spatial orientation, but in the sense of working visual memory. And if the cognitive impairment starts later in the disease, then we can see that particularly functions of the posterior part of the brain, like parietal and occipitotemporal lobe, may be involved because verbal memory, visual functions, and processing speed is being involved. Now, in some studies, cognitive scores have correlated with age and with disease duration, but generally no correlation was found with the number of repeats or with muscular impairment or with education at baseline. So we can nicely see also the pathology, the central pathology, and one of the fascinating things is that actually in cases of myotonic dystrophy in some patients, what was found were clear cerebral sort of impairments, also involving white matter, then cortex with atrophy, and interestingly, intraneuronal neurofibrillary tangles of tau, which we actually found in frontotemporal type of dementia as well. So as I've told you, in myotonic dystrophy type 2, there are less studies. It's not entirely clear whether the wide spectrum of cerebral manifestations observed in type 1 also occurs in type 2, and the jury is still out. Now, there's interesting, some authors, when they do research about myotonic dystrophy, that they try to find a unified hypothesis of what all these changes may be. And because if you try to put tau protein, so neurodegeneration, plus white matter changes, plus atrophy, together in somebody who is having cataract, who is bald, who is having erectile dysfunction, who is having endocrine dysfunction, you can quite easily, with other words, say, okay, that's old age. So one of the hypotheses is that we deal with accelerating ages, with accelerated aging. In this group, we also have mitochondrial encephalomyopathies. You know that there is a whole range of them with phenomenologically interesting combinations, sometimes hard to learn combinations. But we know that these are systemic conditions which affect high energy required tissue. So they are specialized on tissue which really needs lots of energy. And this, apart from obviously brain, are also muscles, also retina, also tubular epithelium. So all these are I would say organs or tissues which really have lots of mitochondria. And this is why we've got such a wide range of clinical features in mitochondrial entities, from from muscle degeneration, cardiovascular disease, movement disorders, diabetes mellitus, renal failure, ophthalmological eye doctors can see them a lot. And of course, we in cognitive outpatient can also see them. So we know that clinically they would present either as a specific cognitive disability, for example, visuoconstructive functioning of the parietal type, then visual processing of the temporal, like occipital temporal Watt pathway, so they would have like visual agnosias and so on, and working memory, which points to towards more frontal lesion. Again, this central nervous system is not related to age, to disease duration, to age of onset, to clinical phenotype, and other things. And commonly we can see them in Kern-Sarr syndrome, in MERF, in MELAS. Again, if we try to put all this together, then we can say that, of course, aging involves oxidative mitochondrial decay. So when one ages, then the mitochondrial function is becoming more and more deficient, and we can see this actually also cerebrally, so in the brain. So it would not be strange if there would be another hypothesis of somehow accelerated aging in these disorders. Now we've got a third group which with possible cognitive deficits, but not defined genetic biochemical abnormality. There's many muscular dystrophies now, one which are quite heterogeneous in their clinical appearance, also in genetics. And we can broadly, from cognitive point of view, we can broadly divide them into those with normal mental development and those with mental retardation, like Fukuyama, like muscle-eye brain, like Walker-Warburg syndrome. And again, if we try to find these the abnormal expression of proteins in the brain, we will find it. So for example, fukutin is expressed in neurons, particularly those neurons which are early in the development, involved in neural migration, and they were found also in the glial cells. In congenital myopathies, cognitive status may be affected severely. Again, it seems that those pathways which involve particularly early migration is rather critical, and most often it may express as a prominent language disorder. Congenital myopathies, which is broad term for any muscle disorder present at birth, or we can view it more narrowly, and of course we would then talk about the Nemelin, myotubular, central core, congenital fiber type, or multi-core. And then limb-girdle muscular dystrophy, again, genetically and clinically heterogeneous group of relatively rare muscular dystrophies, which are characterized by progressive muscle wasting affecting hip and shoulders. There are two big groups and many sub-entities in each group. It's type 1 and type 2, and there are several complexes. One of the most studies is dystrophin-associated sarcoglycan complex of a of alpha, beta, gamma, or delta type. Now, while functions of sarcoglycans is not completely understood, we know now that in the brain, particularly beta sarcoglycan may be involved in the synapse formation. And actually, in rare patients who were studied more in extenso from cognitive point of view, they would find that they had beta sarcoglycan type, and what was found was discrepancy between verbal and performance IQ with a specific language disturbance. And there were some imaging studies also who showed hypoperfusion of the left temporal and frontal lobe, which is very much in agreement with clinic, because in temporal we had the Wernicke center, so center for understanding the language, and in frontal lobe we've got this Broca center for expressing, and in between there is a link between understanding and talking, which is arcuate fasciculus. And in the adult polyglucosan body disease with this impressive pathology and a defect in the in the glycogen pathway due to the mutations in the GB gene, we can find either focal cognitive decline or dementia in approximately 50%. Now, we've got also neuromuscular diseases without or with very poorly or with still unfound cognitive impairment, although quite a lot of studies were done, particularly in the first group. So this is spinal muscular atrophy and facioscapulohumeral dystrophy. Of course, if a young doctor once sees this phenotype of facioscapulohumeral muscular dystrophy, you do not forget it. It's very impressive. And we must say that cerebral involvement is very, very rare. One of the literature which I found was a mental retardation which was described in childhood disease with a very large deletion defect, but this is rare, and it's questionable whether there is the link. And of course, in spinal muscular atrophy, which we know recently very, very well, we know also the genetic, we know also the possibilities of treatment, we know where and what is going on, and it's I must personally say, that it's whenever I meet our colleague Dr. Leonardis, she deals a lot with these diseases as well. I feel sort of happy because I see, how a field of neurology, which was so pessimistic, so sort of hopeless when I was a young neurologist, now is becoming full of hope, and a beautiful field actually to work in it. Now, it's interesting that in early reports that Dubovitz actually compared SMA to DMD and said for children with SMA that they are normal in intellect and some to be even brighter than average. And interesting, there was a range of academic studies comparing some neuropsychological tests or academic tests, and in many studies it came out that academic skills required for verbal component in intelligence tests are most developed in patients with SMA. So it's not really clear, is it something which is negative maybe in some other dystrophies, like positive here, or they simply compensate for physical handicap. And I will finish with the disease, which, of course, if you are a neurologist, it remains with you as a as a important a severe neurological disease which affects motor neurons, particularly in anterior horns, but also in frontal cortex, in brainstem. Now, it's something which we were not aware when I was a young neurologist was this cognitive impairment, and it seems that that cognitive impairment of the type of frontotemporal dementia is quite common. Now, frontotemporal dementia is not a rare dementia. It's not as common as Alzheimer. It usually comes earlier than Alzheimer. If Alzheimer is like 65, 70, then frontal temporals are earlier, 40, 50. And we have like 3 variants. With ALS, particularly one variant is associated, and that's a behavioral variant. It's interesting that they say that up to 50% of ALS patients could eventually develop impairment associated with frontotemporal dementia, and up to 30% of patients with frontotemporal dementia developed motor dysfunction, quite often of the sort of SMA ALS type. What sort of cognitive impairments are often? Most of what I will tell you now goes really into the frontal lobe and into the temporal lobe. So that's apathy, abulia, lack of emotion, reduced spontaneity, loss of inhibition, restlessness or overactivity, social inappropriateness, mood swings, memory loss, loss of speech or language. Now, I put you a photograph which I believe you all know about. So, although on the left side I can tell you many things which can be present in a patient with ALS, you have on the other side a proof that this is not like obligatory, and that the mind of a patient with neuromuscular diseases with ALS, for example, can be very clear, can be beautiful mind, and also the life can be does not need to be short. You see, when we look at the brain of somebody who is having this combination, we can see changes quite clearly. We can see like spongiform neuronal degeneration in prefrontal, temporal lobes, also in the limbic system. And we have a good explanation for it, because the genes for ALS and the genes for FTD overlap quite significantly, particularly the C9orf72. And these same genes here are implicated generally in the central nervous system, in autophagy, in RNA regulation, and in vesicle and inclusion formation. So no wonder that these same genes would kill some other cells there. Now, just to tell you that this frontal lobe, which is so critical for a patient with ALS, that we have a very motor part here. You see here is where the motor cells are dying with apoptosis, but here we have more cognitive part. Here the motor plans are being produced, not executed, but plans are being produced. Here is, if I make it simple, like cognitive or rational part. Here is where brain does abstract thinking, changing of the strategies, working memory. And here, down there, inferior and in mesiotemporal lobe, it is what we call the orbitofrontal cortex, which is very much associated. It is the bridge actually between the limbic system and the dorsolateral and this lateral rational part. And this is why when we describe this, we would say words like social intelligence or emotional intelligence, empathy, and so on. So all this is here. And so we can, and here at the very, very, very end of the frontal lobe, which we call polar frontal lobe, is something what we call self or mind. Here with this part, I can do some metaphysic thinking or ideation, and then this part here, it's called the cingulate, anterior cingulate gyrus. This one is like I quite often compare it to the pistol on the start. So this is the part which gives you energy, which gives you kick off, which gives you the energy to start something. And if your cells are dying here, then you will slip into the abulia, loss of will, apathia, being unable to, just sitting there, not really responding. And you see, all these things you can find in developing frontotemporal dementia in ALS. So I'm unable to plan movements. I'm less able to do abstract thinking, to have working memory, and I can have quite either disinhibited behavior, with maybe aggression or something, or if this part is particularly, then I will have this apathy, this sort of, whereas if temporal lobe will be affected, which also is along frontal in ALS, what I will suffer is I will not really recognize what is this. It's an apple. And then I will also not know what this is for. So semantic and visual what pathway. I think I'll skip this. I will also skip this. Frontotemporal dementia is nowadays quite complex. When I was younger, there was only one frontotemporal dementia. It was called PIC disease, and medical students and young neurologists were very, very happy that there was only one frontotemporal dementia. Now there are more. Now, maybe just to tell you that basically there can be two groups. One is where behavior changes, when this caring father or a grandfather suddenly becomes quite angry or aggressive or behaviorally changed, and then all this other group deals with language, with how I speak, how I understand, and this is not so common in amyotrophic lateral sclerosis. I think I'll skip this. Maybe just to tell you, of course, to illustrate that here in the temporal lobe, we also keep knowledge about what is this. For example, what is apple? And I'll show you an interesting a picture which Dr. Koritnik showed in a recent meeting for registrars in neurology. And this is what does, if you say draw a cat, they don't know really how cat is, so they would draw something in between or draw a chicken. So I think much for your invitation, and I guess it's my privilege now to introduce you Professor Koritnik, the head of the Institute for Neurophysiology. That's my first home, actually, was, and a man who really did such an enormous work in the field of neuromuscular diseases, particularly ALS. Blaz.
Thank you very much. I hope you do see the presentation and you hear me.
Yes.
Okay, excellent. I will try to introduce and speak about the neuromuscular multidisciplinary teams, a way of organizing healthcare system that offers a lot of benefits. Since I do work in the field of neuromuscular disease, it is of course the approach that we're using in this field, but the same approach can be, or let's say should be, also used for the treatment of other diseases, not just neurology, but even further on.
Ej, kaj zdaj z vama?
Let me just.
Can you please mute yourself?
I will try to mute. I think I have.
Se upravičujemo, gospa Gaja sliši.
I just muted her, yes, okay. So you can now hear only me, yeah? Okay. When talking about multidisciplinary teams and multidisciplinary care, one comes upon different versions of disciplinary. So we can talk about intradisciplinary when we are only working within a single discipline, and this is the usual case for any specific topic that we work on. And then we have cross-disciplinary, something that goes across the border of one discipline and uses broader views of some topic from another part. Multidisciplinary is somewhere in the middle, so we have different people from different specialties or different professional fields working together, and each of these persons will contribute his or her own knowledge, specific knowledge, and this is how we try to work. But the way forward, I think, is interdisciplinary. Interdisciplinary teams. This approach will also integrate knowledge. So it's not just each contributing his or her own knowledge, but trying to bring knowledge or care to a higher level, because we're trying to integrate knowledge. And I must say that definitely working in the field of ALS for quite some years, we did reach this level, and we can feel that it's not just contributing, but it's also sharing and integrating knowledge between the co-workers. And then we also have transdisciplinary, and I don't think that I really understand this one, so we'll skip it. Team coordinator is the crucial role and the crucial person in the field of multidisciplinary teams. So he would be a conductor that will take care of all the members and trying to negotiate, trying to coordinate. And I think that we can't really talk about multidisciplinary teams without speaking of team coordinator. So what is the role of a coordinator? She is always the point of first contact for patients and families. Then the coordinator is coordinating the activities of team members. He is the one to determine which person will be responsible for particular tasks. He will participate in care planning, and he will inform the professionals about new patient needs. So whenever some new problems arise, he will be the one to find the correct professional and address the need. And he will also coordinate work with other institutions and other services. And this is something, it's a scheme that is something that how our team works, but I just want to show you, so we can use the same scheme for other fields. But I just want to show you that being a team means that we are part of a huge network, of a larger network that also includes other institutions, other people. Always we have the person with the disease and their carer in the middle, but then we try to weave a network that will surround this circle and that will help and support. And you can see that it goes very far from different specialties to the spiritual care, to rehabilitations and so on. ALS, and I will speak about ALS a bit more because ALS is a special disease. It's a terrible disease and it's special because it progresses very fast. It's probably one of the fastest progressing disease, and it forms a vortex or a spiral, and it's very difficult to keep the pace with the disease. It's difficult for the people with the disease, and it's also difficult for the health professionals. And that's where the team approach is even more important because it requires quick actions. It requires very good organization of medical and other care. And it requires the use of well-established treatment pathways. It actually requires the people to create new pathways and to pave new pathways. And this is the path that we walked for the past 20 years at our center. Our center is based at the University Medical Center Ljubljana. So the center was established by Professor Janez Zidar in 2002. And we offer clinical care for most of the Slovenian patients with ALS. We also perform some research which comes in hand with our clinical work. And the team works as a multi and interdisciplinary team. So just to have an impression of who forms such a team, on the left side, we see the core of our team, people who really work at our institute, who have contacts daily, who work together in many times in same rooms, in same clinics. So we have a coordinator, we have 2 respiratory therapists, we have 3 specialist nurses, more and more neurologists. It's the part-time occupation to work in the team. That's why we have more. We also closely collaborate with a representative from hospice. And then we have people who work quite close, so at the same institution, and we see them weekly. Speech therapists, occupational therapists, neuropsychologists, rehabilitation specialists, ENT specialists, and dietitians. And then we have people who are there for us, who would offer their professional service, for example, insertion of gastrostomy, in initiation of invasive respiration and psychiatry problem. As we've heard from Professor Pirtosek, ALS does have psychiatric problems quite in a significant percentage because it's part of the disease. It can be part of the disease. Now, the ALS multidisciplinary care is in the world is organized over 30 years. And it's not just about medical care, and the roles of the institutions that offer their services may overlap, but certainly the patient always has to stay in focus, and we always need and have to respect the autonomy of the patient. So the patient will be the one who decides what to use, which approaches to take, and so on. And we shouldn't forget about the family. So the families, being usually the main carer for the person with the disease, they also need our support and attention. In Slovenia, we started in 2002, and as the way our work is organized, we have weekly internal meetings and also monthly professional meetings. We used to have them before the age of COVID. And we keep very close communication between all the professionals, also information exchange and contact with the patients, everything with the help of our coordinator. And these are, as I've shown you, the roles in another team that is being formed within the past 2 years, because we've introduced new treatments for spinal muscular atrophy. We also, as a neuromuscular center, see most of the persons with spinal muscular atrophy, and we are now establishing, or have started to work within a SMA team that has similar profiles. As you can see, coordinator, neurologists, nurses, and so on. Maybe slightly different. We have an orthopedic surgeon who joined us recently and an endocrinologist, all based on the patient needs. The guidelines that exist, the clinical guidelines for ALS, clearly state that multidisciplinary care should be available for people affected by ALS. And then we have different levels of the different levels of recommendations, how to use, what approaches to use. As you can see, I won't go into details, but we have, as I've explained, a group of different specialists or professionals. We need to offer regular checkups for the patients, typically every 2 to 3 months. We try to assign a single neurologist as being the main contact, the main carer for the individual patient, not to change the neurologist every time they came into the hospital. And then we need to use different channels of communications within the team members, but also outside of the team. Same is true for spinal muscular atrophy. We've heard already today during the talks, and we know that we have good recommendations that were published 2 years ago. And the recommendations will talk about different aspects of disease, and every single aspect, as you can see from the title, is quite specific. So we need specialists, professionals that are specific for their field, and that's why we need to create the team with all these specialists, including the rehabilitation, orthopedics, nutritional care, and so on. Now, one might ask, why do we really, do the multidisciplinary teams really offer some additional advantage? It seems so when we get some experience, it seems that this is something that offers some advantage, but because it's very important to plan the health system with evidence, to support the decisions with evidence, especially when we want to build a new service and we need money and resources for this research, for these new services. We need some evidence, and there is some evidence that multidisciplinary care improves the outcome of the disease. As you can see from the titles, improves quality of life, improves survival, and that's something that we also looked into in Ljubljana. We've published a paper this year looking at how multidisciplinary care approach can be beneficial for survival in people with ALS, and we looked at the data from our center. I'll just present a few details about this paper, about our research, because I think they are important. So we had 2 groups of patients with ALS. The first group was taken from the early beginnings of our center, from the first 3 years when we established the center, when we only started to organize the team and the multidisciplinary approach. And then we selected another group that was seen at our center within the years 2011 and 12. It's the period where we already had a decade of experience, and we thought that we tried to take a look at the at different parameters to see if there is any difference looking at these two groups of patients. These are some some information about the two groups, the so-called early group from our early beginnings and the late group. As you can see, most of the parameters were not different between the two groups. There were two different differences. One was use of non-invasive ventilation. Quite significant change. As you can see, the late group was using the non-invasive ventilation quite much more than the early group, which is easy to understand because this was part of our multidisciplinary group that we also improved and developed the service of ventilation at our center. And the second thing is riluzole treatment. Riluzole as being the only drug registered in Europe for treatment of ALS. In the early beginnings, it was not widely available for the patients. It took some time, some years to have it available. And you can see nowadays, or 10 years ago, a big proportion of patients were using the drug for treatment. So we looked at how the two groups changed. As you know, unfortunately, ALS is a terrible disease, and the survival is rather short for most of the patient. And we were looking at the parameter that is always being looked upon when we try to establish or when we try to introduce new treatments. And as you can see, the difference between the two groups showed a significant difference in survival. So the patients that were in the second group did have quite longer survival, and the survival benefit is actually much larger, 2 to 3 times larger than the benefit of currently available drug, the riluzole drug. So we tried to use a statistical model to really prove that the actual multidisciplinary approach is associated with this survival, because one would think that solely using more invasive or non-invasive ventilation and using more riluzole can be the reason or the cause of increased survival. But you can, of course, account for this difference putting riluzole and non-invasive ventilation into the statistical model. I won't go into the details, but as you can see, despite taking all these parameters, age, gastrostomy, non-invasive ventilation, riluzole into account, we still see that the group effect, so to say, so being in the later group was important enough to double the or reduce the hazard ratio for survival into half. But on the other hand, this was now an advanced statistical approach. We did see that it seems that a part of the effect might be due not just more use of non-invasive ventilation, but more different use of non-invasive ventilation, because we took into account that we are using more non-invasive ventilation, but we were trying to statistically model whether a difference in using ventilation can also be a reason. So our conclusions from these studies were that the main factors that affect survival in these groups of patients was using riluzole, non-invasive ventilation, gastrostomy, and also the multidisciplinary team approach. That was the first conclusion. The second conclusion was that there was increased use of non-invasive ventilation and riluzole as the team was getting more experienced. And then the third conclusion is that the multidisciplinary approach itself has improved the survival with patients with ALS. And mainly this might be due to improved use of non-invasive ventilation. So I think this is one of the evidence, one paper out of a group of papers that can also contribute to our future approaches to maybe expand the way that we treat patients within different subspecialty groups. Now, another important thing, and now I'm talking specifically of ALS because of its progressive nature of the disease, that is that we are also not just developing multidisciplinary specialist care. We are also, I'm talking about Slovenia, I'm talking about University Medical Center, trying to develop the palliative care approach, because the contemporary approach to palliative care, at least within neurology, is that it needs to be integrated within neurology. So we are not talking about having someone with a very difficult disease as being neurology, being taken care by neurology, and then at some point when the disease progresses, turns into palliative care. We should always work hand in hand with palliative care, and this is something that some consensus also described a few years ago, that there is actually pressing need for increased collaboration. So it's not just a situation in Slovenia, it's also a situation in the rest of the world that it needs to be, especially for progressive neurological disease like dementia, Parkinson's disease, multiple sclerosis, stroke, and so on, that also palliative care approach needs to be developed. And I think that it needs to be developed as a part of multidisciplinary teams. This is just a graphic representation how it has to be integrated within the scope of the medical care. As you can see, the palliative care approach should blend into the therapeutic approach, because we cannot really distinguish between two of them, and this is something that we need to develop our services also in the future. And there is a clear recommendation regarding the multidisciplinary palliative care teams. The assessment and care should be provided by such a team, and they have to have at least a physician, a nurse, and a social worker or psychologist counselor. The second recommendation is that a patient should have such an assessment and access to specialist palliative care for the ongoing management. Something that we are also developing and again is being developed in other countries, some more, some less, is the respiratory multidisciplinary team. A lot of neuromuscular diseases have respiratory problems as a major part of disease itself, both ALS and spinal muscular atrophy, for example. And in this case, and as I've shown based on our data, the respiratory care should be one of the most important components of care that we offer, and that's why it needs to have its own organization and development. So we have our respiratory therapist and also collaboration with pulmonologists for years now. We still think that the future development needs to go into the direction of specialized respiratory units that will also offer home care for those who need the respiratory care. And so this is another area that is important and needs to be further developed in the future. Now, let me finish by looking into the challenges in the terrible age of COVID-19 that we all live now. The challenges are always can be good or can be bad. I think that COVID, of course, brought many bad things to the way that we live and that we work, and had brought up many problems for the medical system, many challenges. But on the other hand, I think we can also see it as a push towards a different organization, towards looking for maybe better solutions. And in this way, I see that this problem of COVID also brought some ideas how to develop in the future. Telemedicine being one important aspect for ALS and for neuromuscular disease in general. Just recently listened to a talk by a Scottish professional who showed the numbers of a huge increase of patient-doctor engagement over internet only. So a lot of the consultations were or are being done only using telemedicine. And I think a lot of this will stay like this even when we reach the post-COVID stage, whenever this will happen. So that's something that, as you can see from the date, and this paper was already published before the COVID era. But I think that it's now just a big stimulus to really try to use telemedicine, maybe monitor respiration at home, talk to the patients using video systems if they have problems traveling, provide communication with different professionals all together within a single session, as we have a Zoom session today, and so on. So I think this is an important way forward for the approach. I don't think that we need to replace the proper person-to-person contact, and I'm really sorry that we need to talk this way, that I'm actually looking at a blank wall behind me when talking to you, but I know that the times will return when we'll still be able to sit at the same table and talk to each other, but then this can offer quite a lot of advantages too. Now, another approach that we are using now more and more, this is our mobile team, a very tiny team, as you can see, a tiny car. I can climb into this car and also take the respiratory therapist with me with all the baggage. And this is how we started working this spring. Where when people had problems coming to the hospital, especially those who use the non-invasive ventilation and have problems traveling, even without COVID. But nowadays, when we shut down a lot of the doors in our hospital, this was the way to reach people outside of the hospital, and we are still using this approach now. And we do go to people's home, and I think that this is a good policy, and we are now discussing how to introduce this into the system for the future use too. Now, what is both plus and minus of this COVID era is the online meetings. It was a pleasure to participate at today's meeting with you, but as I can show you, the EAMDA meeting is one of the 5 meetings that are going on at this very moment. So at the same time, I'm in the middle of the virtual World Symposium on ALS that's going on from Wednesday to Friday. At the same time, the African Congress of Clinical Neurophysiology is going on, and because it is virtual, people from all over the world can attend. So although being called African, it's actually World Congress. At the same time, there is a nice event giving out MEDIS awards for good researchers, also neurologists. And I'm just part of a discussion group of Zoom where we speak and talk and discuss about these mobile teams, how we'll introduce them. So I did decide to stay with you, and thank you for staying with me. And I think we are both available if there are any questions. Thank you very much. And these are all the collaborators that are part of the team, and I really wish to thank them for their effort. And of course, there wouldn't be any teams if there wouldn't be people who are very good friends of ours. Društvo Dystrofiko, we have a very long-standing collaboration, and I hope that this will go on at least for the next 50 years. Both Društvo Dystrofiko and our institute celebrated 50 years of existence last year. Thank you.
Thank you both for your nice presentations. Maybe I have just one question for you, Docent Koritnik. I'm wondering, because you nicely presented the effect of multidisciplinary teams, do you maybe also translate this good practice also into other specialties? I mean, I don't know, I'm working mostly with rheumatologists and dermatologists. In rheumatologists, you can see some initiatives going on in these directions, but not as good as you presented now. But anyway, do you also share this among others?
I think that, thank you. As I said, I think that this approach should be used by many other specialties and many other groups of diseases, especially rare diseases, where a single specialist does not have capacity of taking good care of every aspect of a disease. As it happens, we try to collaborate at least within the clinical, within our medical center, Ljubljana. But most of these groups or teams will grow because of the needs. So when we recognize the needs of people with such diseases, then we will try to grow and build a team around these needs. So the ALS approach that we are using might not be the same approach that people in rheumatology will use, but anyhow, I think many principles can be very useful. So sharing knowledge between the teams is very important, and this might be the transdisciplinary approach that I've mentioned in the beginning. Maybe sharing practices and finding some good things in another group and translating it into your group should be used. And I hope that we can do this more in the future.
Thank you.
Okay. Are there maybe any other comments or questions for Professor Pirtosek too? Otherwise,
I would like to say a word on behalf of our Muscular Dystrophy Association. I would say big thank you for both of you. I know mostly, not mostly, both of you quite well, but Professor Pirtosek mostly because my big colleague and my boss, Boris Susteršič, was telling me a lot of him. I know Blaz for quite a few years now, and I know our association wouldn't be so, I hope I dare to say so successful without the help of such a doctors as you two are. So I hope, I don't hope, I'm quite sure we will cooperate pretty well in the future too. Thanks.
Thank you very much, Ivo, and I'm sure that the cooperation will go on, and I really enjoy working in this field, especially because we have such a good collaboration.
and sincere thanks from my side. You know, such a cooperation is always two-way road. I mean, you learn from us, but we learn from you, and it's a beautiful journey.
Thank you. I agree.
Okay, so I think it's time to move on. Dinner time, unfortunately, each for himself. This year, it would be a pleasure to continue the discussion over a glass of red wine or non-alcoholic drinks, but I think we should do it separately tonight, and look forward to next year when we could again do it together in the same room. Thank you very much for joining us, and have a very nice evening, and
Thank you.
bye-bye.
Bye-bye. Stay well.
Thank you.
Stay well.
Thank you. Bye-bye.
Thank you very much. Great presentations and lovely to participate. Thank you.
Thank you. Bye.
Thank you. Bye.